But you notice she has reasonably good facial aesthetics, even though she does have this type B growth trend. But the A and B is less than 4.5 degrees. It was 4 degrees when we started, and note that after treatment, in spite of the maxillary movements, the reduction has only been 1/2 degree. The headgear must be worn 14 hours per day throughout treatment. Treatment time will be in the neighborhood of 18 to 21 months. Now let's talk about something very pleasant. The next slides, please. Type C and Type C subdivision. If the tracings reveal that growth is equally forward and downward, with lower face growing forward more rapidly than upper face, with a decrease in the size of the A and B, the facial growth trend is Type C. Growth processes are very favorable, and treatment should not be difficult. Now, the difference between the Type C and the Type C subdivision is this. In the Type C, growth is horizontal and vertical about equal. In the Type C subdivision, it's more horizontal and not very much vertical. So let's discuss this type, which is the Type C. Magnitude of maxillary tooth movements. Well, now let's see what has happened during her pre-orthodontic guidance. During her pre-orthodontic guidance, and she was a very miserable patient, and her growth treated her more than I did, because she came in when she darn well pleased. 2 years of pre-orthodontic guidance, FMA has dropped from 36 to 32.5, mandibular incisors have stayed the same inclination, 94. FMIA has improved 3 degrees as a result of a flattening of the FMA angle. The A and B has gone from 5 to 3.75, meaning that lower face is growing forward more rapidly than upper face, or there could not be, the A and B would not be diminishing in size. Now, as a result of her treatment, FMA has further decreased during treatment 3 degrees, or 2.5 degrees. The mandibular incisors were moved from 94 to 77 degrees. FMIA from 53 to 73 degrees. A and B during her treatment was further reduced from 3.75 to 1.75. Now note that the magnitude of maxillary tooth movements is not as much as we have seen in the previous cases. Growth is doing a swell job for us here. Prognosis is very good from the standpoint of both occlusion and facial aesthetics. No treatment is indicated until the full eruption of all 4 permanent cuspid teeth. And in many instances, it might be smart to wait for the full eruption of the bicuspid teeth and not get in her mouth until you could band every tooth. Maxillary controlled headgear treatment is necessary only during the first 6 months of full appliance therapy to prepare anchorage and to secure axial inclinations of the maxillary incisors. During this time, the headgear need not be worn more than 14 hours per day. When the above has been accomplished, treatment should be continued with intermaxillary elastic force and the headgear used only when needed. Anchorage preparation will be less severe than in the previous cases. Treatment time will be from 12 to 16 months. The next slide. Now this is the subdivision. This is the subdivision, and observe here in projector 4, little growth in the vertical dimension and much growth in the horizontal direction. Whether making a subdivision is smart or not, I don't know, but there is a difference between Type C and Type C subdivision. In the Type C, growth is equally horizontal and vertical, and in the Type C subdivision it's mostly in the horizontal and not so much in the vertical. Now then, if the observation tracings reveal that growth is mostly forward and but slightly downward, with lower face growing forward more rapidly than upper face, with great improvement in the A and B angle, the facial growth trend is type C subdivision. The growth trend is most desirable, and treatment should be neither difficult nor lengthy. Fortunately for the orthodontist as well as the patient, 60% of all our cases fall under the type C and type C subdivision category of growth trends. Now, in these instances, no treatment is indicated until the full eruption of all permanent cuspid teeth. 14 hours per day headgear wearing is necessary only during anchorage preparation, which is minimal in these cases. Intermaxillary force is used to correct the mesiodistal relationship with the denture. One can reasonably expect beautiful facial changes as a result of good treatment. Treatment time will be from 9 to 14 months. Now, so far as I have been able to ascertain, there is no correlation between the size of the FMA and the type of the facial growth trend. The three types of growth trends may be found in all variations of FMA. Now, those are casual observations and would bear further investigation. In all type C and type C subdivision growth trend cases, where the molar relationships are normal and the angle A and B does not exceed 4.5 degrees and is improving, I would suggest that active treatment not be instituted prior to the full eruption of all permanent teeth, including the mandibular second molars. Now, in all class 2 non-discrepancy malocclusions, when the A and B angle is improving during observation, it is good procedure to use the Klein headgear with reservations. And my reservations are that it should be used as a restraining mechanism, restraining growth, and not as a tooth mover. And any time you open up space between your first molar and your second deciduous molar, you're not using it as a growth restrainer, you're using it as a tooth mover. And the pressures applied should never open up space between those two teeth. And when used that way, oftentimes this will be the only treatment that is necessary in non-extraction class 2 cases. But they're few and far between, and you have to use some judgment in its usage. The Klein headgear treatment is most effective as a treatment adjunct in those 60% of cases in which lower face is growing forward more rapidly than upper face. It is, like other treatment mechanisms, least effective in those cases where the growth processes are such that A and B angle is worsening during observation. In my opinion, it's suicidal in those cases. Now let's take a look at the next and the last slides. Now, if by chance, and you fellows, this pertains to your pocketbook, if by chance you have never before correlated the variations in facial growth trends and their influence on treatment procedures, you might do so now. If you do, you might learn that little Johnny in projector 1 here, who has been under treatment for 24 to 30 months, has not been as uncooperative as you may have thought. And little Susie over there on projector 4, who has worn braces only 12 to 15 months, and who comes when she damn well pleases, and is about to be retained, has not been as cooperative as you may have thought. You might also conclude that the variation of fees in your practice is most unrealistic and inequitable. It required more than twice as much time to treat little Johnny in projector 1 as it did little Susie in projector 4. Think nothing of it. Just so it wasn't a Coke bottle. Eliminating abnormal swallowing and tongue habits as causative factors, the evidence suggests that malocclusion accompanied with type B growth trends are apt to develop an overjet following orthodontic treatment. This further suggests that such malocclusion should be actively retained by means of a Klein or similar headgear, as I've just outlined, to be worn as needed throughout their growth periods, as a restrainer of growth but not tooth mover. Now, orthodontists have observed that some children appear to have normal occlusion at 14 or 15 years of age. Then suddenly there is a collapse in the mandibular incisal area. Some attribute this collapse to the oncoming third molars. I suggest that more often than not the collapse is the result of a type C growth trend. In such cases, particularly deep overbite cases, the mandible is growing forward more rapidly than upper face. The mandibular incisors engage the lingual surfaces of the maxillary incisors, and one of two things occurs. Either the maxillary incisors are moved forward, or the mandibular incisors are uprighted and tipped lingually, which cause the development of irregularities in that area. This further suggests that all treated malocclusions with type C growth trends should be retained with a cuspid-to-cuspid lingual bar. It also suggests that it might be a mistake to use a Hawley maxillary retainer with a labial wire too long. If you feel that the patient needs retention up above, it might be very smart to substitute the wire for a light elastic on your maxillary Hawley retainer. Many of us have observed that axial inclinations of some of our once too retrusive maxillary incisor teeth have greatly improved during and following retention. This occurs only in those cases where the growth trend is type C and lower face is growing forward more rapidly than upper face. In these instances, mandibular incisor cutting edges contact the lingual surfaces of the maxillary incisors and carry their crowns mesially to improved axial inclinations. Now, if the A and B angle ranges upward from 6 degrees in a child 8.5 to 9 years of age, one should suspect either a type A subdivision or a type B subdivision growth trend. In either instance, treatment will be lengthy and difficult. That is not always true, because I have children at 8.5, several of them, with angles of 6 degrees or better who have favorable growth trends, type C. Now, any orthodontist who attempts to treat with any type of light wire technique a patient whose A and B is 8 to 10 degrees and whose growth trend is type B subdivision has my sympathy. This also applies to the use of the Klein neck gear as a total appliance. The headgear is a must in such cases. Sorry I didn't have this better organized, fellas, and thanks for your... And we're going to have some more talking, some more discussion throughout the day about the seared extraction procedure, because I want you to go home thoroughly prepared to handle these kids as they should be handled.
And so on, the course of the cuspid, you have to do what I tried to demonstrate that we do in our practice, and it's very simple when you do this in an orderly fashion. We do not develop x-rays every day, but when they are developed, they're placed on that card. And my girls and myself are not hunting an hour or two for some lost x-rays. They're on that card in the cellophane folder. They're dated so that we know the date the pictures were taken. When they're sent to the oral surgeon to remove teeth, the complete set of x-rays are sent in a folder with the request, please do not take out of the folder. And then make a note who you sent them to, because half of them will forget to return them to you. Now over here on the other side are 3 children that I've been following their pre-orthodontic guidance. You have to show some interest in them if you're going to learn something about growth. You're going to have to take serial head plates. There's few of my patients that pre-orthodontically and through their treatment that do not receive a dozen head plates. And when I continue that, I have a growth picture of the child from the time I see them at 7 until as long as I live. Some of them up to 21, 2, and 3, still getting head plates. You're not going to read it in the books. You're going to live it and learn it in your offices. I'm going to first read this, and then we're going to discuss things that I know are pertinent to use, such as mistakes that one makes when he begins to the transition in his practice from permanent dentition to mixed dentition. I'm going to have Bob Telford speak a few minutes following myself, because he has just gone through that experience the last 4 or 5 years of this transition, and he now limits his practice to the mixed dentition, as do I. Now, serial extraction of teeth to minimize the severity of a developing malocclusion within the mixed dentition is a serious decision for any orthodontist to make. He should never attempt such procedures with the thought in mind that pre-orthodontic guidance procedures will result in a cure-all that will eliminate the necessity for future orthodontic appliance therapy. When you discuss this with a parent, don't even give them a suggestion that this might be all. I'm going to show 3 cases that I have followed, the most satisfactory ones that I have followed, and who have not been treated, so that you can get a general idea of the condition of these mouths under the best circumstances, or the best I have. Now, it is true that serial extraction procedures, when properly executed, will, as a rule, result in self-correction or the prevention of the development of irregularities in the incisal segments of both maxillary and mandibular dentures. It is also true that such procedures, eliminating the existence of abnormal tongue and swallow habits, will permit the mandibular incisors to migrate or tip lingually to positions of functional balance, thus giving the orthodontist a valuable clue concerning the correct location and inclinations of these teeth. If such information is recorded and the positions and inclinations of the mandibular incisors maintained to the conclusion of orthodontic treatment, little difficulty will be experienced during the retention period. Now, some of these children, other than a bite plane to maintain vertical height, need no retention. All this is good that we've been talking about. But what about the adverse effects that result from serial extraction procedures? The aftermath of serial extraction procedures, again eliminating adverse tongue habits and swallowing habits, is the self-correction of the irregularities of the mandibular incisors, and their lingual tipping are from 2 to 13 degrees or more. As the mandibular incisors tip lingually, they also elongate, unfortunately, creating, as a general rule, a deeper overbite than the original. This invariably results in an increase in the curve of speed. In addition, as a result of some mesial drift of the teeth in the buccal segments, the second premolars usually erupt with mesial axial inclinations that vary from slight to severe. The spaces between second premolars and cuspids will vary from nothing to 3 or 4 millimeters, depending on the amount of tooth bone discrepancy. In other words, some of these, if the discrepancy is not large or virtually closed, and in others, when the discrepancy is just half the breadth of a tooth, that's as far as they'll close. If left untreated, speak louder. If left untreated, especially when the mesially inclined second premolar crown is in contact with the cuspid crown, an early periodontal problem is
inevitable.
So you can do damage in these mouths if they're left untreated. To sum up, eliminating exceptional instances, the aftermath of serial extraction procedures, unless followed by orthodontic mechanical therapy, creates a greater hazard to the longevity of the denture than would have been the case had such procedures not been followed up. The average Class 1 malocclusion, accompanied by reasonably good axial inclinations of the teeth in the buccal segment, from the standpoint of denture health is, in my opinion, preferable to the same untreated case in which serial extraction procedures were followed, which resulted in the development of deeper overbite, mesial axial inclinations of the teeth in the buccal segment, and broken contact points. Now, in my book, my feelings are so strong concerning this matter that I will go into considerable detail to illustrate the end results of serial extraction procedures in the hope that by so doing, the uninitiated will not wreak havoc on innocent children. No orthodontist, periodontist, or general practitioner has the moral right to venture into this field unless he is completely qualified and willing to correct all abnormal conditions that result from serial extraction procedures. Now, unless the following conditions exist, there is little or no hope that, as a result of serial extraction procedures, the patient has any chance whatsoever of not requiring mechanical orthodontic therapy as a result of serial extraction procedures. Now, these conditions are: the malocclusion must be Class 1, with a reasonably good A and B relationship of one jaw to the other. 2, there can be no semblance of a deep overbite condition existing prior to such procedures. 3, as a general rule, the Frankfurt mandibular angle must range up from 30 degrees, upward from 30 degrees. In addition, the patient must possess a type A or type C facial growth trend. Now, here is a little warning that I would like you fellows to note. In reviewing the serial extraction cases, it becomes quite obvious that, as a rule, the degree of overbite of the incisors is in direct ratio to the size of the FMA angle. Therefore, now remember this, therefore one should take a long second look at low FMA angle cases before instituting serial extraction procedures. Now, I refer to those cases whose FM angles range downward from 20 degrees. To begin with, these types of cases usually present deep overbite problems, which most certainly will worsen during the time these procedures are being executed. Now, not the mistakes I've made, that I hope you won't make. Now, the first mistake you're going to make, you're going to get into these mouths too soon. You're going to get itchy. And it's going to cost you some money. It cost me $10,000 a year in practice for 3 years. Because I got in too soon and had to spin my wheels and wait for teeth to erupt, not having brains enough at the time to temporarily remove the bands and wait. And as long as a patient has an appliance in his mouth, you have to see him at least once a month. At least I think you do. And so I spun my wheels, as you will, because you didn't get in at the proper time. Now, my biggest mistake, and I make lots of them, fellows, was in the beginning. I usually had the patient, the child down and took complete record. And I talked to the parents, and I received $25 for my time. And then I watched these kids without sending any statements all through their serial extraction and all through their head plates, and I advised and that's all I did. Now these children, when I wanted to use them as demonstrators, came back to me, some of them 4 or 5 times, and I paid them $5 apiece to let you fellows look at their teeth. So the end result, oftentimes, of my 4 years' effort was the $25 that I returned to the children. So that's costly. But the worst thing about the whole thing was this. The mandibular incisors straightened up, and the teeth looked pretty in front. And the parents say, oh, hell, why should I spend $1,000 to have the teeth straightened? This is good enough. And that will happen to you unless you follow the suggestions that I'm going to make to you. Now, when these parents decide themselves, rather than you, that this is good enough, 2 things have happened. You very probably, your services has been a disservice to the patient in many instances. And secondly, you've been hit in the pocketbook pretty briskly. Now, a better way, in the way that I hope you will follow, I have learned the hard way, and my stiff-necked friend Bob Telford, I couldn't convince him until recently that he was foolish and not getting some money for what he was doing, and he now knows better, I'm sure. He'll tell you about it. Now, a better way is to have a distinct agreement with the parents and tell them that I am going to minimize the severity of this malocclusion by certain procedures that we'll have to follow over the next 2, 3, or 4 years. And at the end of that time, this child must be treated. And I give them let's say a $1,200 overall fee. I take complete records, models, intraoral x-rays, photographs, and everything, and I present the case to the parents. It takes me 1 hour and 45 minutes to get the records ready. Now, I make every tracing in my practice. I point every tube. I take every photograph. I take every lateral head plate. With Francis' assistant, I handle the position, so forth and so on. I do all these things myself. And taking my time into consideration only. After that, they prepare the records. They develop and mount these pictures and process the head plates. I put on the triangle. But my time is 1 hour and 45 minutes to take these records and talk to the parents. And I don't talk 10 minutes to the parent. I try to educate the parent. I give them a talk of 1 hour, showing photographs, discussing growth, so forth and so on, so that they have a comprehensive idea of what we're attempting to do and how children's faces grow, so forth and so on, and what we can expect as an end result of treatment. All those things are talked about in detail. And so they decide that they want this pre-orthodontic guidance program. I send them a bill for $100 for records and a discussion. And I have it definitely understood that they pay $100 a year for this pre-orthodontic guidance. I see these patients every 3rd or 4th month, and I just don't look and say goodbye. I take 4 intraoral x-rays in the quadrants, the buccal quadrant, so that I can follow the growth, the eruptive rates of these teeth and learn when and when not they should be removed. Now, this first year I spent an hour and 45 minutes, and that included 3 visits more to my office for pre-orthodontic guidance. So I have 2 hours and a quarter, for which I've been paid $100. Now, the second year I begin to catch up. They have 15-minute appointments to let me examine their mouths and take these 4 x-rays. So I get $100 for 1 hour's work. I'm getting up in the money. And the second year, I get another $100 for doing the same. Now, in the meantime, I'm taking series of head plates if I think that they are indicated. I have to, I can't predict a growth trend, usually, under from 12 to 15 months. But always during pre-orthodontic guidance, I take a head plate 15 months after the first head plate, and to verify what I think I have found in the first head plate, I take another one sometime later to make sure that I am predicting the growth trend correctly. Well, anyway, the third year I get another $100, and I spent a little more time. I've drawn on the triangle, but chair time, no. So that this goes on, and some of them it's 4 years, and I get $400 for guiding them. Now, when it comes time to treatment, the patient has paid a third of this fee. And he's not going to throw that overboard as readily as he would if he only paid $25 like I originally charged. And so, for the child's sake, and for your own protection, it's infinitely better to get paid as you go along, so that the parents of this child have got this fee partially paid. You know yourself, you might laugh off $25, but you don't laugh off $400 very often. And so, psychologically and practically, it's a much nicer arrangement when you're paid as you go. Then again, there's this. This patient may be transferred. They may leave. You have been paid for your time. And what you have done, if you have done it correctly, you have reduced the treatment time on that patient from a third to a half, so that the balance of the fee that you quoted, if it's a reasonable one, will amply pay the man who is to treat this case for his treatment. There'll be no hard feelings between parent and the orthodontist. So for heaven's sakes, have this agreement with the parent and have your fee partially paid for by the time you start treatment. Again, up here, I have 3 of the several cases that Francie is displaying to show you the true picture of the aftermath of serial extraction. Now, 3 of these cases we're going to show have not been treated. One of them, by the name of Kathy Boyd, is most illuminating. I followed this child over a period of 12 years. In fact, she worked for me for a while until she was married about a year ago. And when I make tracings of her head and her face, and I superimpose on geometric center of mandible, the indications are that face closure was affected by about 20% mesial displacement of the teeth in the buccal segment and about 80% lingual tipping of the mandibular incisors. And I've run across some other interesting things that bear mentioning, and you fellows might be on the lookout for. These samples that I collected, some 150 or 200 now I have, some of them I've had occasion to call back and take head plates 12 years later. And in the few that I have done this to, I have found startling things. I think Beggs advocates that drift of the posterior buccal segments. The patients that I have redone, the indications are that there's not mesial drifting of the posterior teeth. The FMIA has gone, in my daughter's instance, she's from 25 to 44, has gone from 66 to 72. And she wasn't an extraction case. And apparently this intercontact shortening of the dental arch is taken care of more by the distal positioning of the anterior portion of the mouth rather than the mesial drift of the molars. So these are the things that you can get interested in. And then another thing about these flat faces. I want you men who have practiced orthodontia longest to think in their minds, the flattest faces you have in your practice are non-extraction cases, period. Now think about it. The flattest faces you have in your practice are non-extracting cases. These people with dished-in faces we're talking about now, whether treated or untreated, the more you find more dished-in faces with full complement of teeth than you will in the extraction cases. And you keep that in mind and see if that is not true in your own practice. Now, what do you do if you time these kids wrong and you're in there spinning your wheels? Take the bands off. It doesn't take a half hour to take the bands off to scale up the teeth and get the patient out. And it doesn't take more than an hour and a half to put them back on. And I spend more than that time making a retainer. When my kids, and I have occasion to have a few bad children, I make 2 retainers that are lost in 3 weeks. And the third time the kid comes back, he doesn't know it. He has an hour appointment, he goes back with an appliance up above and a headgear on his head. And say, now, Mr. Smarty Pants, you just wear this until you can be responsible. I'm telling you the time limit. You have those bands cleaned up and saved and they're ready to go. You can slap them back in there and put a headgear on him in an hour. And you're sure curing, quick. And it's less time than it takes me to bend up the wires for a retainer. Bob Telford, you'll never be prepared. So now get over here and tell them the experiences of a young man who has gone through the labor pains of going from the mixed dentition to the permanent, from the permanent dentition to the mixed dentition. Tell them the errors of your ways, your problems, so forth and so on. Now remember, you have a lot of lungs back there. Don't cut me off. Let's go off too long. Okay. Bob Telford is one of our very talented instructors. Health problem or system is lost. I have to care for him, and I cannot go back or he never talk. So that is the Bob, don't talk too long.
Actually, I should quit when I'm ahead. But I'll get back to what you just said, I hope, Dr. Tweed, if you give me time, which you probably won't. You cut me off, so I'm going to start. I'd like to preface my remarks with the fact that it is impossible to satisfy all of the people all of the time, but you have to try. And that's what I'm going to try to do. because the master has decided 20 minutes ago that I'm supposed to be prepared for this now. Okay, first of all, there is no need to fear this pre-orthodontic guidance thing. It is big leagues. It is not easy. You're going to have dentists in your area telling you all you got to do is pull 4 buys. That's what the orthodontist is going to do, and it's going to straighten up. But you're the orthodontist, and it's just possible you may get back some of those, and ethically you can't tell the parents that they've been in the hands of somebody who didn't know what he was doing. And now they're in your hands. And before you get there, I would suggest you probably should find out what you're doing. Now, what you have learned so far in this course applies to the 12 to 20 age group. You have just had 2 concentrated weeks, like you've never had probably before. And maybe you haven't discovered it yet, but I'm sure you're all aware of it. Now, the first thing that you have to do when you get home is take first things first. And that's try to get your practice back down to where you can handle, or up, I don't care which way you're going, Tweed technique and Tweed philosophy in the best manner that you know how. You may find after a couple of years that it still isn't clicking quite the way it was expected to. You have the course here, and you're welcome back. And no, nothing further on that. Now, if you sit and wait until you have learned everything that you've learned today, or this last 2 weeks, and you can do it as well as Dr. Charles Tweed, and then I'm afraid that you'll retire before you ever get into serial extraction. So you're going to have to hit a medium somewhere, and I'm going to try to explain that medium, if possible. Now, as you are well aware, Dr. Tweed treats these cases beautifully. You see them, he shows the plaster. What he's going to show you now is based upon all of this sweat he was just talking about and all the money he's lost. And he doesn't want you to fall into those pitfalls. But first, learn the course. You understand? And now we're going to talk about what we do about serial extraction. Now, Dr. Merrifield, who is the co-director in this course, has approached serial extraction with due caution, extreme caution. And if I am correct in what I understand him to say, he has said to me in the last week or 10 days that he handles 2 cases per month that have been developed because of serial extraction into his normal caseload, which in the main is 12 to 20 age group, the group that you learned about in this course. You understand? Is that right, Laverne? All right. Now, if he takes just 2 cases per month, and this is Laverne Merrifield, and you know what a fine orthodontist and director, co-director he is, and he can do 2 cases a month. And he's been at it for, what, 5 years, Laverne? Then you can see some of the problems, and you fellows have probably already got 4 buys out. You're already in serial extraction. Okay? And 24 cases per year is all the co-director at the present time manages in his practice in order to get the results that he feels will qualify to satisfy his conscience under the direction of Charles Tweed's philosophy and treatment procedures. You get what I'm talking about? Now, so far, I just talked. Now I'm going to give some advice. There's a difference between advice and suggestions. Advice is cheap. Suggestions cost money. So I'm just going to give you some advice, and I'll be cut off here pretty quick, so I better move on. Dr. Tweed has asked me to discuss my experiences since I've recently made the transition from young adult to full caseload, all my cases come from serial extraction. I take nobody beyond the age of 12. I have an associate in my office, Dr. Rad Fisher, who's here in the course with you, and though he has a very few serial extraction cases, I have not wanted him to get involved in that until he's learned pure Tweed in the best fashion. And it takes a little time to learn that. You can't learn everything today. You're going to have to wait until you see the results of your treatment cases to determine whether you did it right or wrong. On the basis of my limited experience, and it is limited, I'd say this. A, first try to learn Tweed treatment as best as you possibly can. I've said it before, I'm saying it again. Now, when you've finished that, when you are beginning to think in FMA, IMPA, FMIA, and A and B, which were just so many angles and figures and faces and stuff flying by, when you were beginning to be able to think in that particular fashion, then I would suggest, and for heaven's sakes I might add, A and B, don't forget it. It's on there too, you know. Charles Tweed's formula, or his analysis, is FMA, IMPA, FMIA, and A and B, plus a head film discrepancy, plus a total discrepancy, and you heard a little of that this morning, but you have to have all those facts at your fingertips. Now, when you have that, you can start one case, I would advise, per month, and you charge for your services. I didn't, as Dr. Tweed mentioned. And I won't say why, I just didn't. But you have to, because pretty soon you're going to find yourself doing free orthodontics for everybody. And you have some girls to pay. And you got everybody coming to you. So you charge for your services as a trained observer, and you will be a trained observer by then, and you'll know what you're looking for, and you owe this to the public. That's why you came down here to learn something about Tweed, I trust, because you'd like to give a little bit more. And the future of orthodontics itself, as Dr. Charles Tweed has said, is in the 6 to 12 age group. And you're going to have to make this transition, or you're going to have to let it go by. That's your decision. Either way, you've got to try to do the best you can. And everybody's situation is going to be different. And I cannot, as I said when I prefaced it, I cannot answer everybody's setup, because somewhere, someplace, I'm going to be talking to one person and it's the exact opposite for another. So, enough of that. Now, after 4 or 5 years of serial extraction technique where you've taken one case a month, you will discover that very few work out to your satisfaction. But if the public is satisfied, you've done your share, and you've been charged, and you've not lost money. If they decide to quit there, and they're still a lot better ahead than if they'd never started at all. then you'll discover that the vast majority of them will require further orthodontic banding. All the way from full treatment to maybe just upper appliances, maybe anything, I don't know. This gets into the exciting part of it. This is when every case is really different, and every wire you bend is different for every case, and why you have to have 45 minutes to an hour, because you must study that, and you must have the time to bend the wire, and you can't bend one wire this week and hope to put on headgear when the upper one has got nothing but a round wire on it. But you haven't got time, and so you're going to schedule them in next week, and you're gone already. So the problems they multiply. All right. Now, when you will then start cutting back on your young adult, that's your 12 to 20 group, because you've got to provide for this group you've already been studying for 4 or 5 years. Huh? And then you will be able to start the treatment on the 6 to 12 group, and some of those are now about 12 years old, and they're ready for banding. Finally, by limiting your practice to 12 and under, you will find that you can go full-time with those cases, and that nature has done some or all of the treatment for you. Now, in consequence, you will be more efficient because you've been in this for a long time and you've studied hard to get there, and you will have been through the mill, so to speak. And the cases that you have before you, you will be able to treat in a shorter time. And you will still have time to spend 3 or 4 months at the end of treatment to put on that extra little zilch that makes the difference between a beautiful treatment and one that leaves something to be desired. Now, you can quit anywhere along the line as long as you've tried. When you reach that point, you will be producing a fairly good facsimile, and it is a facsimile, of what Dr. Charles Tweed has spent 38 years of his life working a 36-hour day and 8 days a week to show you right now. And when you're there, he's going to be that much farther along the route, and you can come back and find out what happened, because he'll know the answers again. Now, that's enough. Dr. Tweed hasn't cut me off. And what I wanted to say was, I wanted to finish this with just a few quick remarks. First of all, Dr. Merrifield took a picture off on the back end back there that he's going to have mounted on a board. It shows, you've seen this, did anybody see Charles Tweed, the bullfighter? Well, Dr. Tweed is an extraordinary bullfighter. And he was down in Nogales one time, and he fought this bull. Now, he didn't use a sword because he didn't have it, and he didn't have a cape. He just had the bull, and he did such a good job that they awarded him 2 ears and 3 tails. Now, this is hard to get, but of course, he's familiar with Siamese brackets, and this was apparently a cross between 2 Siamese bulls, and it gave it 3 tails. I mean, I can go into all of that, but the thing that you have to remember is that, and what I wanted to get at, was even though Dr. Merrifield has the sword now, you saw him pointing it, you see, and Dr. Tweed will supply the mantle, they have now dumped it in my lap. And I'd like to tell you a little story about me, on me. And that's that Dr. Tweed was mentioning that he went to the biggest wedding he'd ever been to. Well, I sat here and listened to Dr. Tweed just a little while ago, and he said some very nice remarks. But referring back to the bull ring, there were 3 bulls. a big bull, a medium-sized bull, and a small bull, in fact, a little bull, and they were trotting down this road together. And they came to a point where they looked out and there was a pasture full of the most beautiful cows you'd ever seen. And the big bull says, "Well, boys, I'm going to pasture." And he cleared the fence and left. And the middle-sized bull and the little bull just kept right on down the road. And they kept right on a-running. Pretty soon it came to another pasture, and there was another group of cows. And this time the medium-sized bull said, "Oh-ho, my turn. Goodbye." And he cleared the wall and went out to the pasture. That left the little bull. And the thing I wanted to tell you, and it's real important that you get it, referring back to Dr. Tweed's remarks, a little bull, that was still running, you know, goes a long, long way. And Dr. Tweed has just given it to you in my presence. Thank you.
While you're still assembled, I'd like to take just a minute to publicly thank the instructing staff. I think they've done a beautiful job for you, and George and Art, Herb, Charlie, Gail, Bob, I certainly thank you for the efforts you spent with the class, the time you put in at the tables, and I think the class would probably like to give you a real good hand for the work you did.